presenting you a very rare case, but less than 250 cases reported in the whole literature, the Cogans Syndrome. So this was presented in the Sir Gangaram Hospital 4 months back. A patient, 74-year-old male, came with complaints of high-grade fever for 1.5 months, along with bilateral red eyes. You can see the bloodshot red eyes for the duration of 1 month, along with bilateral hearing loss. And it was such that the attendant was complaining that he could not hear if he is standing by his side also, and it just progressed so much within 20 days. So the patient is of Varanasi, known case of hypertension, hypothyroid, BPH, and status post-COVID, and he was COVID positive in April. Treated at home only, no oxygen support required, no steroids given. Vaccine status is to be uh, talked about. He got vaccinated once in June with Covishield, another dose in September. So those were the two doses. And he presented just 20 days after the vaccine, second dose of vaccine of Covishield. So else he has no history of any similar episode in the past, no history of any cough, oral or genital ulcers, joint pain, bleeding from any side, rashes, headache, weight loss, low stools, vomiting, ear or any eye discharge, or any kind of dizziness. And there is no history of any substance abuse, non-smoker, no alcoholic, and bladder and bowel movements were regular. So he got admitted in a hospital in Varanasi itself on 10 days after the onset of symptoms, on 29th or 30th September, and he received then IV meropenem and vancomycin till 20 days, followed by he was brought here Lama 20 days back. So on examination, pulse rate was 88, all peripheral pulses were present, BP was 140/90, he was afebrile. Valor was present, as already shown you, bloodshot eyes, vision was 619 in both the eyes, and bilateral SNHL was there, and EAC was clear, as general and systemic examination were within normal. So based on this, we were thinking of the differentials could be the inflammatory eye disease, local causes, chlamydial infection, herpes simplex, varicella, leprosy, or mycobacterial tuberculosis, the most common. Or could be an inner ear infection like viral autoimmune hearing loss, could also be a possibility. Then CP angle tumor, vascular insufficiency, paralymphatic fistulas, drug toxicity, vancomycin toxicity, mostly we were thinking of demyelinating diseases, MS. So then it could also be the combination of both, most probably then it would be a vasculitis, a small vessel, or the newly formed category, variable vessel. Then also could be sarcoidosis, though it didn't complain of the respiratory symptoms that much. Just one episode of desaturation in the past admission in Varanasi, but the history was present 4 days after getting admitted to the hospital, and just one episode of desaturation. No any skin like nodules, erythematous nodules to be seen. Then syphilis, Hutchinson triad wasn't present. Then walked Kanagirada, all sort of occurrence, autoimmune diseases basically, APLA, Behçet's, UC, Crohn's, any CNS lymphoma, vasculopathy. So on admission, the investigations showed all were within normal with HB of 10.7, and the acute phase reactants, ESR was 110, CRP was 201, and ferritin was 970, along with IL of 6 of 22 and D-dimer of 0.99. This we went through a thorough examination, though he was already evaluated on the admission. These we repeated, basically some of them are repeats. So Montux, quantiferon code, TB, autoimmune walkout, along with NCAS, HLA markers for 27 and 51, serum A's, anti-CCP, IgG4, EBV, RT-PCR, all infection workup basically, along with vancomycin level and NCC and EMG. All were within normal with HbA1c of 5.1%. APLA workup was negative too. So PTA was done, showed bilateral moderately severe SNHL, and this was done just a day after getting admitted to the hospital. And on slit lab examination, there was interstitial keratitis bilaterally, and the fundus showed normal steady. So imaging was done. X-ray was non-conclusive, nothing remarkable, and on ultrasound whole abdomen there was mild hepatosplenomegaly. So this MRI was done on the prior admission, and so was CT head and PNS, which was within normal. So 2D echo showed EF of 65% with mild AR, LV diastolic dysfunction grade 1 with a PSP of 35 mmHg. So we proceeded in our hospital with full body PAT scan. We showed increased FD uptake as he was suspecting vasculitis. So it was evident on the PPAT scan, showing the increased uptake in all the large vessels along with medium-sized vessels. So, according to the protocol, we would have gone through the nasal carotid artery or lymph node biopsy, but the patient was unwilling for any of the mentioned. So, in our differentials, it was large or variable vessel vasculitis. Could have been GCA, LTA, but not that of our typical presentations, and neither could have been idiopathic urethritis. So, we were left with Cogans Syndrome. So, what is a Cogans Syndrome? So, first of all, there are less than 250 cases reported in the whole literature, and mostly in the young adult. So, this could be a atypical one. So, though all other findings were all cited in the Cogans Syndrome. So, let's see. So, it's an autoimmune disorder characterized by non-syphilitic IK and bilateral SNHL, and the SNHL is of acute duration, and so is all the symptoms, abrupt onset of symptoms, along with relapses. So, there's a brief history about Cogans. So, it was first described by Morgan and Gartner in 1934, and earlier it was believed to be similar to Meniere's disease, then hence proposed diagnostic criteria for the typical and atypical Cogans, and pathogenesis involves autoantibodies present in the endothelial against the endothelial antigens. So that's the reason for SNHL, along with the hypersensitive to infectious agent that could be a trigger point. And most commonly it has been linked to reovirus type 3. One third of the patients with the Cogans have an antecedent viral-like illness. So, and also triggers are antibodies to HSP70 and smoking. So diagnostic criteria involves exclusion basically. So we need to rule out vestibular auditory symptoms, causes such as neoplasm or any stroke. Need to perform CT and MRI, which was within normal in this case, along with slit lamp examination, and the confirmatory is biopsy. So how do we proceed with the treatment? Immunosuppressants, reducing the reaction, nucleic methotrexate. We start with weekly 15 to 25 mg per week, along with folate. As you can, there is no response after 3 to 6 months. Start on azathioprine 0.5 to 2.5 mg per kg per day, and mycophenolate mofetil 2 to 3 grams per day, along with NSAIDs for pain relieving management, and corticosteroids reduce the oculovascular signs. So also needs to add topical and systemic both. And so how we managed this patient was, we started with methylpred 40 mg twice daily, and with methotrexate 50 mg once a week, along with topical steroids for eye and ear. So this was just on the day 2 of starting these steroids and topical steroids. You could see the remarkable recovery. The bloodshot eyes vanished almost. So on day 4 again we repeated PTA, and it regressed to moderately severe to moderate bilateral SNHL. And this was followed later on after the discharge of the patient, 10 days later on, and the patient was able to hear even if someone is speaking from, I would say, 100 meters apart. So that was a remarkable and evident recovery post-steroid therapy. So how is the prognosis in this patient? So about 90% of the patients suffer severe hearing loss, total bilateral deafness of abrupt onset. Less than 5% become blind if no treatment given. Death usually is from CHF or cardiac failure after disease progression. Most manage their symptoms and limit the patient's treatment.